Hi, my name is Terry Pancook, and I'm going to show an external cervical resorption defect I recently treated. The patient presented with a mandibular first molar with a type 2 Heithersay resorption defect affecting the bucco-cervical aspect of the mesial root. A limited field cone beam CT scan was taken, highlighting the area, and you can see there's one main portal of exit at the bucco-cervical root, which is fairly large in diameter and communicates periodontally. There are no other areas of portal of entry noted on the root surface associated with any additional areas of resorption. Clinically, the defect could be probed on the buccal. The pocket probed no deeper than 2 millimeters, although there was bleeding and it was quite inflamed. The patient also presented with a 3/4 gold crown, a buccal pit amalgam with a shallow enamel limited crack. The first visit, the canals were all clean, shaped, and filled with calcium hydroxide. The resorption defect was internally prepared using the CT mapping to guide the preparation. Next, a cabot temporary is placed without a spacer, compressing the calcium hydroxide into the canals and resorption defect, creating an effective seal, making sure it was not leaking laterally. We will now show video of the second visit. Here we are injecting 90% trichloroacetic acid, which is injected into the mesiolingual canal, and you can see it coming up the mesial buccal canal. I'm now injecting it into the distal canal. You can see the bubbling, now applying the endoactivator to the TCA to disperse it in the canal system. I am now adding bleach to the TCA in the canal system, which creates a reaction producing water, chlorine gas, salt, and carbon dioxide gas. The chlorine gas presumably improves the debridement, as a gas has more diffusion than a liquid. The endoactivator is used to agitate the liquid and provide better penetration of the fluid. Now I'm using the microsuction to evacuate the fluids from the canals and pulp chamber. Next, I irrigate with 17% EDTA and agitate each canal with the endoactivator for 30 seconds. I edited the 30 seconds at each canal for brevity. I finally use alcohol again to flush the canals and dry before using paper points. Let's review the final canal clearing sequence before filling the canals. First, I flush with alcohol, then evacuate with the microsuction. Next, I place TCA, then I add bleach to the TCA to get the desirable chemical reaction products. Then I evacuate the bleach with the microsuction. Then I place 17% EDTA and I agitate with the endoactivator in each canal for 30 seconds. Then finally I evacuate with the microsuction and flush with alcohol, then dry with paper points, and the canals are ideally cleared and dry and ready to be filled. This is the cone fitting check film showing the cone fit in the mesiolingual canal and the distal canals. The canals are filled by placing the coated fit gutta-percha points. This is the one being fit into the mesiolingual canal. I usually check it twice to make sure the cone is completely coated in the apical third of the cone. Then I place it, I sear it off with a touch and heat, and then I go in with a number 10 Schilder plugger and I compact it lightly. Now in this case you're going to see this is the vertical compaction of the warm gutta-percha technique. I usually do 5 waves of compaction. This is the touch and heat applied for 3 seconds, and then I compact with the number 9 Schilder plugger, and I can see the cement escaping along the sides of the cone. I'll go back in and repeat. Here's the touch and heat applied again for 3 seconds, and I go back now with the 8 plugger, pushing the excess gutta-percha off the walls down onto the pad and compressing. I increase my pressure as I proceed apically. Here's the touch and heat again, 3 seconds applied, and in this case I'm backfilling with the gutta-percha gun, and you can see how I'm expressing the material into the mesobuccal canal because the two canals are confluent, which means I didn't have to place a cone in the mesobuccal canal and get excess gutta-percha and sealer into the resorption crypt. So there's a little bit there, but that's easily removed. So I use the percha gun to backfill, and I bring it right up to the orifice of the resorption defect area, not wanting to really get it into the bone area at all. Compact it. Now I'm going to fill the distal canal like we normally do. A supplemental cone to keep the cone from collapsing, and the same sequence. Touch and heat, sear it off, lightly compress with the shoulder 10 plugger, clearing the gutta-percha off the walls, pressing, seeing excess sealer escape coronally around the cone. The touch and heat for 3 seconds. Now applying the number 9 plugger, again moving the excess gutta-percha off the walls, compacting the pad, applying pressure, allowing the gutta-percha to escape along the sides. Using the touch and heat, applying 3 seconds, removing excess gutta-percha. Now going again with the 9 plugger. You want to capture the maximum cushion of gutta-percha with the plugger. Again, using the touch and heat. And now applying the hot shot gutta-percha gun and backfilling with the molten gutta-percha. So we've filled all the canals, and on the mesial buccal canal, we've filled it just to the level of the base of the resorption defect, which has been prepared, and we have fantastic hemostasis. Now I'm applying chloroform to dissolve and remove all the excess gutta-percha. Use a round micro brush to swipe it away. Then I apply alcohol to stop the reaction, and then clear all the gutta-percha away. This is what it looks like, completely cleared and cleaned after obturating. The resorption prep is now ready for biodentine placement, which was compacted into that prepared defect, and Cabot was placed over the top, and a few days later, once the biodentine is set, a final restoration was placed over the occlusal surface. One final point I'd like to make is the use of TCA, which in some circles is viewed as a toxic liquid. I have used TCA on every single root canal case and resorption case I've treated since 2018 and have had no untoward effects other than occasionally minor spilling on the gum tissue, which turns white and it heals within a few days. There is no pain associated with the use of TCA. In fact, the use of TCA seems to decrease inflammation and pain for some reason which we are currently investigating. You can see in this still photo that there is gross bone resorb. This was perforating resorption, and you can see the bone tissue directly exposed, which TCA has been soaked on that exposed bone. There's no negative effect. TCA is a limited acid and does not harm tissues or bone. It is a safe liquid to use, and it's a very useful liquid to use in root canal treatment and resorption treatment. Here is the post-treatment radiograph. You can see a couple of accessory canals and a distal loop. The Cabot temporary filling was compressed to push the Biodentine completely into the resorption prep without creating voids. I intentionally overbulked the Biodentine so that it squirts out any communicating area. You can see some excess Biodentine at the MB line angle on this photo. I basically flatten it with a Woodson after the Biodentine has an initial set. I usually have the patient wait in the chair for about 30 minutes before I finish off the cervical Biodentine and recontour it. This is the final radiograph after restoration. I hope you enjoyed this demonstration. That is it. Thank you.